There's a sentence that gets said in exam rooms every single day, and for a lot of people it lands like a death sentence for the life they love. The doctor points at an X-ray and says, "You're bone on bone. There's nothing left to do. We just have to replace it." And in that moment, a person's entire future collapses into a single grainy image and a single word, inevitable. I'm Dr. Gurpreet Padda. For 30 years, I've worked at the intersection of interventional pain, regenerative medicine, and metabolic biology. And I'm going to tell you something that the assembly line will not. That sentence is a lie. Not a malicious lie. Most doctors genuinely believe it. But it is built on a way of thinking about your body that is decades out of date, and that is now being directly contradicted by the science. Today, I want to take you deep, deeper than a 7-minute visit ever could, into what bone on bone actually means and what a landmark 2026 clinical trial just proved. If you've heard that sentence, I want you to know that the grief you felt afterward was real and it was rational, because it wasn't really about the knee. It was about everything the knee carries. The hike you stopped planning, the floor you can't get down onto with your grandchild, or worse, can't get back up from, the trip you keep postponing, the quiet, creeping surrender of a life that used to say yes, now negotiating with a joint. And on top of that loss, you were handed a brutal binary: live on painkillers and wait, or submit to a major irreversible surgery. No third option, no agency, just manage it until it's bad enough to cut. I have sat across from thousands of people carrying that verdict, and almost every one of them asked me some version of the same quiet question: is this really it? Is this the best my body can do? And the honest answer, backed now by hard data, is no. It is not the best your body can do. You were simply never offered the door marked biology. So let's be precise, because precision is where the lie falls apart. Bone on bone is a description of an X-ray. On the Kellgren-Lawrence scale, it means grade 3 or 4. It means significant joint space narrowing, where the cushion of cartilage has thinned dramatically. That is a real structural finding. I'm not pretending the loss isn't there. But here's the part almost nobody explains to you. The amount of cartilage on your X-ray and the amount of pain you feel are only weakly related. Let that land. Researchers have shown that people with severe changes can have modest pain, and people with mild changes can be in agony. Cartilage itself has no nerves and no blood supply. It literally cannot generate the pain signal you're feeling. So when a physician stakes your entire future on the gap in that image, they're reading the wrong map. So if the pain isn't simply the gap in the image, then what is it? This is the entire pivot. Your knee is not a mechanical hinge with a worn out part. It is a living biological environment, a chemical ecosystem, teeming with signaling molecules, immune cells, and inflammatory messengers. In an arthritic knee, that environment is on fire. The lining of the joint, the synovium, is inflamed. It's pumping out a storm of destructive pain-generating chemicals. That is what's driving your pain and damage. And here is why that changes everything. A gap in an X-ray you cannot unthin. But a chemical environment, a biological fire that you can influence, that you can shift. The question was never, how do we fill the gap? The right question is, how do we change the biology? And now we have rigorous evidence that we can. Before I show you the evidence, let's be honest about why the end of the road story is so dominant. Modern orthopedic medicine was built around structure and mechanics. If a part is worn, replace the part. It's a powerful model. Joint replacement is a great achievement, but a model built entirely around structure has a blind spot the size of your whole biology. It sees the gap, it doesn't see the fire, and there's an economic gravity to it. The system is optimized to move a patient efficiently toward the operating room. The slower work of changing a joint's biology doesn't fit the conveyor belt, so biology gets skipped, not because it doesn't matter, but because it doesn't fit the machine. When you were told nothing can be done, what was usually meant was, nothing within this structural surgical model can be done. That is a much smaller statement than it sounded like. Let me get specific. Osteoarthritis is not passive wear and tear. It is an active, low-grade inflammatory disease. Catabolic forces are winning. These cytokines drive the destruction of tissue and sensitize the nerves around the joint, cranking up your pain. Enzymes like MMP3 chew through the matrix. Cartilage breakdown products like COMP spill into the bloodstream. CGRP amplifies the pain signal. This is the real disease, not a gap, a self-reinforcing biochemical cascade. And the reason this matters is simple. Everything I just named is measurable, and if it's measurable, it's a target. Can a treatment move these numbers in advanced disease? For a long time, we assumed the answer was no. In 2026, Lacko and colleagues ran a randomized controlled trial in exactly the patients everyone gives up on: 90 people with grade 3 and 4 knee OA. These weren't easy cases. They were on the waiting list for a total knee replacement. They were randomized into 3 groups: PRP, cortisone, and NSAIDs, tracked for 6 months. So this wasn't a testimonial. It wasn't a clinic's marketing. It was a head-to-head comparison of biological therapy against conventional treatments in the hardest possible patients. So what happened? In the PRP group, pain dropped significantly by 3 months, and here's the crucial part. It stayed down through 6 months. Function, stiffness, the whole WOMAC score that captures how a knee actually performs, all improved meaningfully, and only in the PRP group. Meanwhile, the cortisone and NSAID groups, their improvements were transient or absent. Several patients in those arms dropped out and went to early surgery because their pain was never controlled. And one more finding: opioid use was significantly lower in the PRP group. People needed fewer narcotics to get through their days. Now, I'm going to be disciplined here. This was a single-center trial, not blinded. It's not the final word. But it is real, randomized evidence for bone-on-bone knees. But symptoms alone don't satisfy me. The question is, did the treatment actually change the biology of the joint? This is where the study becomes genuinely important. They measured the molecular fingerprints in the blood. In the PRP group, the destructive markers went down: COMP, MMP3, IL-6, IL-18, TNF-alpha, and CGRP down. And at the same time, the protective anti-inflammatory and repair signaling markers went up: STREM2, SRAGE, and TGF-beta1, a growth factor for anabolic signaling. These shifts were significantly greater than in the controls, and several held at the 6-month mark. This wasn't a fleeting chemical blip like a cortisone shot. Cortisone is a sledgehammer that suppresses inflammation temporarily, then wears off. PRP did something different. It nudged the biology, and the biology held. Read that again. The PRP didn't just make people feel better. It measurably calmed the fire and kept it calmer. It shifted the entire chemistry away from destruction and toward repair. So let's demystify PRP. We take a sample of your own blood and we concentrate the platelets, your body's first responders at any site of injury. Platelets are packed with growth factors: PDFG, TGF-beta. We are not adding a lubricant or a numbing agent. We are delivering a dense biological message into a diseased environment. It's not magic, it's signaling biology. Your own cells concentrated and redirected, telling a joint that had given up on itself to change its behavior. We asked the system to shift from war to repair. Now I have to say the most important sentence in this entire film: we are not regrowing your cartilage. The gap on your X-ray is not going to close. Anyone promising a brand new joint from an injection is selling you a fantasy. The RESTORE trial in JAMA showed PRP didn't regrow cartilage. That finding is real, and I respect it. So how do I hold both truths? Pain and structure are decoupled. We are not changing the architecture of your knee. We are changing its biology and its behavior. I would rather tell you a smaller true thing than a bigger false one. The goal is to give you back years of your life, honestly. And that honesty is what makes this credible. So if we're not regrowing cartilage, what exactly are we offering someone with a bone-on-bone knee? We're offering something the surgical model can't: control of the timeline. The authors of that 2026 trial concluded, in their own words, that PRP works as a safe bridge to arthroplasty. Suffer now or cut now? What if you didn't have to choose? What if you could calm the biology, reclaim function, and decide when or even whether to have that surgery on your terms? But here's the catch. Not all PRP is the same. It's one of the least standardized treatments. 2 clinics can use the same 3 letters and inject 2 completely different products. Research shows you often need a high specific concentration of platelets, billions, for a durable effect. If a clinic never measures the platelet count, you bought a lottery ticket. At our practice, we treat the injectate like the biological drug it is. We measure it. Fidelity is the difference between a signal that lands and money that doesn't. There's a second reason PRP fails: the terrain. The injection lands in a body, not just a joint. If that body is metabolically on fire, you are planting seeds in hostile soil. We don't just inject and hope, we assess the metabolic drivers, the systemic inflammation, the fuel you're running on. We work to calm that fire first. Precision injection into a prepared terrain. That combination is the entire game. Everything else is theater. It's why the therapy succeeds when the whole system is addressed. Let me be straight about who this is for. This is not a universal cure. Major bodies still classify PRP as uncertain because of the field's inconsistency. I hold it exactly where the science holds it. Promising, supported, honestly limited. For some, a replacement truly is the right next step. I'll tell you that to your face. The only way to know which one you are is a real evaluation of your knee, your imaging, your biology, and your goals by someone who treats you as a whole system and tells you the truth either way. Step back with me. The end of the road is not a biological fact. It's a failure of imagination. The imagination of a system that only knows structure and scalpels. But the moment you see the joint as a living biological system, a chemistry you can influence, a fire you can calm, a terrain you can prepare, the whole map redraws itself. Suddenly there are doors everywhere. The old model saw a wall. The 2026 data is just one door, opening in the room everyone said was empty. Your body is not a machine winding down toward inevitable breakdown. It is a dynamic, adaptive system with far more capacity to change than you have been told. There's a name for what I'm really offering: metabolic sovereignty. Sovereignty means self-rule. Stop being a passive passenger on a conveyor belt profiting from your decline. So reclaiming command of your own physiology isn't just good medicine, it is quietly an act of independence. It's taking the one asset that everything else in your life depends on: your body, your mobility, your capacity to move through the world, out of the assembly line's hands and back into your own. We're not just treating a knee, we're handing you back the authorship of your own decline and turning it into something you get to direct. What does this look like? First, we look at the whole picture: your knee, your imaging, and your metabolic terrain. We treat the body the injection lands in. We build a plan around your biology, not a flowchart. We prepare and measure the injectate with precision, and we walk beside you through a guided recovery. This is not a quick shot and a wave goodbye. It's a physician-led, data-driven process. No hype, no fantasy, no miracle serum, just precise biological medicine. So here's my invitation. If you were handed that sentence, bone on bone, nothing to do, and something in you refused to accept it, trust that instinct. Come and get a real evaluation. Let us look at your knee and your biology and tell you honestly whether you're a candidate for a regenerative bridge or whether replacement really is your best next step. Either way, you'll finally have the truth and a choice. And if you're a physician watching, I know the skepticism. I share it toward hype, but the data is real, randomized, and peer-reviewed in the patients we too often write off. We are in St. Louis, right next to the airport, because our patients are pain refugees who come to us from all over the country, done with the assembly line, and ready for medicine that treats them as a whole biological system. You do not have to accept the edge of someone else's map as the end of your road. Your knee is a living environment. Your pain is a fire that can be calmed. The end of the road was always just the edge of an old map. Come let us help you draw a new one. This is Dr. Padda at Regan.md. Stop managing your decline. Start directing your biology. Stop managing. Start regenerating.